Okay, I think we're going to go ahead and get started. Just to let everyone know, this session is being recorded, and we are going to send out the recording and the slides, and we might even have a resource by the time we've got the recording and everything all cleaned up to send out to you guys that we're going to talk about at the end. But I'd like to welcome everyone to our panel Q&A about workplace violence and policy development around workplace violence. We know that this is an issue that everyone is facing, and it's a pretty involved, nuanced policy to develop, and it involves a lot of different disciplines across the healthcare facility setting. So we just wanted to bring together a group of experts that represent the whole scope of the planning team and give you guys an opportunity to hear how they answer some questions and then ask some questions yourself. Next slide, please. So this is just a little bit about iPro HQIC. We are a federally funded Medicare hospital quality improvement contractor operating in 12 states, and we're looking at data-driven, dynamic, collaborative ways to reduce harm. And one of those harms, of course, falls into emergency preparedness and response, and that seems to be where workplace violence is living right now. iPro is joined in these efforts by health-centric advisors, the Kentucky Hospital Association, Clarent, Q3 Health Innovation Partners, Superior Health Quality Alliance, and the American Institutes for Research and QSource. Next slide, please. Just a little housekeeping about today. Everyone but the speakers are muted, and we are encouraging you to ask questions in the chat. But the way this is going to work is we've got people monitoring the chat, and we will be reading those questions out loud so everyone can hear them. And if we don't get to your question today, the contact information for all the speakers is provided at the end, as well as my contact information and Katie, our other emergency preparedness contact information, and we can get you the answers if we don't get to them today in the hour that we have together. So the way the session is going to work today is we have 5 questions for our 5 speakers, and we're going to let the speakers answer those questions, and then we're going to go to the chat, just so it doesn't turn into pandemonium. Next slide, please. So here we are with our first question, and up first, we have Mr. John Hamm from the Kentucky Hospital Association, and John is the Associate Vice President of Workforce Development for the Kentucky Hospital Association. Welcome, JP. And,
thank you, Tracy.
Here's our first question. Where do you start when you're developing a workplace violence program?
I've got 7 quick steps here, and I'll do them, like I said, I'll do them quickly. I mean, the number one thing is you need to have strong and very genuine buy-in and support from your C-suite and your leadership. That just has to be the number one concern, and just have that genuine buy-in. That also includes the middle management, because sometimes we all know people roll eyes at the C-suite at times, but all levels of leadership, but it starts with the C-suite. Then, of course, is creating or updating your policy, procedures, and training. There are a ton of resources out there, the American Hospital Association, state and local associations like mine, Kentucky Hospital Association, Joint Commission. And when you're doing this, I would include all levels of staff, not just the C-suite, but all levels of the staff when you're relooking at your procedures. One other thing to not overlook, this may be the lawyer in me, is the regulations of your state. So for example, in Kentucky, there's a Health and Family Services regulation that if you're going to be using any restraints on behavioral health area, that training has to be approved by the cabinet itself. I would strongly suggest adding consultant to train staff in de-escalation, defense, and documentation. KHA, we're in partnership. Yep. We offer free trainers for our hospitals. So
JP, you're cutting in and out there a little bit.
I do not know. We're live streaming a press conference, so this may be interfering, but I'll get a little bit closer there. So KHA, we have a consultant that's offering train the trainer, so the consultant doesn't need to go to each and every hospital, but that person is doing the training for the folks to go back and then use their resources. Another big piece is contacting local law enforcement. They may be in there every so often helping with the patient, bringing someone in that's been arrested, for example, but really giving a tour to local law enforcement and making sure also that they understand your state and local laws. So, for example, Kentucky just passed a law that it's now a felony for workplace violence in the emergency department, but maybe not all the local police know about that. And so, and they need to understand that this is real life issues, that when they go into the hospital, it's just like someone being attacked on the street, because sometimes they think it's just our problem, not theirs. Then I would work with staff to ensure that, and these are some of the questions we're getting to, so I'll be brief, to ensure that reporting of an incident is understood and not too onerous. So one thing we've learned from one of our hospitals is that they had personal addresses to put in when you're reporting it, and that stopped people from wanting to report it. They didn't want to put that personal information into the system. And finally, which is again another one of the questions, is strong follow-up, debriefing, and triaging for events. And this is not just disciplining employees when things go awry, because sometimes employees do things well, but it's really for their mental health and making sure that when a bad incident happens, we're supporting those employees, which helps with retention and support.
We're going to get a little bit into next how you assembled your multidisciplinary team, and we're going to hear from Michigan. Sherry, I believe this is the question. If you wouldn't mind bringing the microphone for your conference.
Can you hear me all right?
That's pretty good.
All right, so my name is Sherry Wierzinski from My Michigan Health. We actually started looking at this back in 2018 before regulations even came out around workplace violence. Our employee health department noticed kind of an upward trend with workplace violence. And so went to actually our board of directors and kind of shared what they were seeing and got support to start looking at this and to form a task force. So we started with a small group. There were probably 8 or 10 of us, and we started looking at our data. And we were surprised by what we found in our data. We expected to see most of our incidences occurring in our emergency departments, our behavioral health units, and places like that. And what we found is that, in fact, a lot of these instances were occurring on some of our med-surg units, some of our physician offices, those sorts of places, which was a little bit surprising to us. And we did have a pretty serious incident where we had a provider, mid-level provider, who went into a patient's room. The patient was able to pin this person down on the bed and was choking the provider. As luck would have it, security happened to be walking by and was able to intervene and help her. And what we learned from that was that that provider did not realize that she could fight back. She thought she just had to take it. So there were a couple of lessons I think that we learned from that. One is that staff had kind of normalized this behavior and just decided it was, part of the job of being in healthcare, and there was really nothing that could be done about it. We also found that, or felt that we probably weren't getting all of the reports submitted to us about incidences that had happened. So our first steps were really just to kind of increase awareness, get people to report more, when these incidents were happening, and realizing that this is not acceptable behavior, and that we don't have to just put up with it. So that's kind of where we started. So we put together some posters with pictures of our own staff members and basically said that assault is not a part of our job, and letting visitors and patients and things know that we aren't going to tolerate that in our facility, and that we could potentially take legal action if we felt it was warranted. So that's really where we started. We started trying to have people have more increased situational awareness. So we put together a series of articles that went out in our newsletter that gets published every Friday to everybody across the health system. And then the other thing we did was we implemented the BRASET assessment, which helps predict which patients might become violent. So we built that into our electronic medical record. Staff were required to complete that assessment on admission and then every shift. And then, we expected them to kind of implement strategies based on the patient's risk level. What we found, though, is that it was great. We had it in the medical record, but people weren't really using it the way that it needed to be utilized. So even though we had this assessment, there was no way for people like facility staff who might come up, or environmental services, or the dietary staff coming to pass a tray. There wasn't really a way for them to know that this patient had a potential risk for violence because it was all in the medical record. So what we've done recently is we actually created a stoplight sign, which we borrowed from Michigan Medicine. And essentially it's just a little kind of a strip that has a red, yellow, and green with the, R for red, Y for yellow, G for green. So if we had colorblind people, they could still see it. And based on the BRASET risk assessment, the nurse slides it to display what level of risk the patient is. And that's placed outside of each patient's door. It's also on our ER cards and our transport cards, so that if the patient's being transported somewhere else, whoever's transporting that patient also knows what that level of risk is. And so, if they're green, then obviously staff can enter the room. If they're yellow, there might be some extra precautions that they take, bringing another staff member in, making people aware. If they're red, they might be reaching out to security. So we've implemented that. That's probably been in place for a couple of months. It's been pretty well received and being utilized much more effectively than just having that assessment in the medical record. We've also kind of taken that a step further and said, okay, that's great when they're in the hospital, we know what their risk level is, but what about our clinics that patients may go to after they've been hospitalized? So we've been able to work with our electronic medical records team so that they have that information available to them in the office setting in case that, that patient presents there. We've also done the same thing for home care. So across the health system, people can be aware of what the risk level is. We've also, then we've kind of expanded our task force. We probably have close to 40 members, I would say, on our task force now from all kinds of different disciplines. We have our chief nursing officer from the health system. We have representation from frontline staff, physician offices, managers. We have a couple of positions on our task force, and we meet on a regular basis. And we have probably 4 or 5 different subgroups that we've created. So one subgroup deals with education. One looks at the data itself. What are some of our other subgroups? We have a root cause analysis group. So these subgroups kind of work outside of our task force and bring back what they've learned. There's a communication task force. So lots of different subgroups. Another big focus that we've worked on has to do with training. So historically, our organization has put staff through crisis prevention intervention training, CPI. But what we found is that is a very kind of general program. It's not really specific to healthcare. So we started looking around and we are in the process of switching over to a different education product called HSS. And the reason we chose to go to this is that it is very much more healthcare focused. So probably will resonate with staff better than the CPI that we've traditionally used. So we're kind of in the process of converting to that. Just trained our staff, but we'll be training our other staff. We've also implemented active shooter training. So that's part of our employee incentive program for this year. We have to have a certain percentage of our staff and leaders attend active shooter training. Part of the active shooter training includes going back to that department and doing an assessment for the department to say, okay, if there was an active shooter, where would you hide? What could you use for weapons to fight with? And so the security team comes up and does that. We have different modules that go out for our learning management system for staff. We have created a class called Working with the Difficult Customer. That's been very popular with some of our physician practices. So that's available. We're looking at offering what's called SHARPS training, which is sexual harassment and rape prevention training. So that's another thing we're looking at. We've also done assessments of our physical environment. So our safety, security, and emergency preparedness manager has physically went to every site, looked at things like barriers, panic buttons, lighting, all of those sorts of things, and made recommendations to executive leadership, which has been taken to the board. We also had the local police departments come through each of our facilities so that they have increased familiarity with us, so that in the event that we would have an event, they're more familiar with our location and how we're set up. I see the question about who leads our overall committee. It's actually Sue, our Director of Employee Health. And again, we have a big committee, probably 40 people from various different groups. So that's kind of a brief overview. Did I forget anything, guys?
I don't think so. I think that's a pretty good overview. Of course, when we developed our policy and procedure, we also looked at the regulatory requirements from the Joint Commission, some of the newer requirements, as we've been doing it for years, but we wanted to make sure we had everything in place.
I think there's a couple of questions in the chat. Katie or Becky, do you?
So the 5 subgroups, we have a communication group, we have an education group, a root cause analysis group,
Communication.
a signage group.
Yeah, and our subgroups continue to change as we look at other initiatives that we want to implement. And so it's really a fluid kind of situation where we will add, some subgroups may drop off a little bit, or they'll just report to the whole committee periodically. New subgroups develop as we look at other areas that we want to explore and initiatives that we might want to implement.
And the program that we're switching to is called HSS.
How about the vendor that does your education?
Oh,
Someone's asking.
So we use a learning management system called Connect. We build the modules and publish into our learning management system.
Yeah, the active shooter training is all customized by my security department. We stole it from everyone else, but we made our own customized. That way it's sustainable and you can teach it. You just don't bring somebody in once. You have the capability of it continuously. That's what we wanted.
And then we have an entire education department that, as Sherry said, they make a lot of the learning modules and do a lot of the research for the modules. So the situational awareness type modules, recognizing behavior escalation, caring for the difficult customer, were all things that our education department researched and created.
And then the assessment that we use to, for risk for violence is the BROSET. It's BROSET. So the BROSET, is done in the EMR, and then based on that risk level, I think they get a score of 0, 1, or 2. 0, of course, is no risk, or low risk. 1 is moderate risk. 2 is high risk. And then, again, outside of each door, there's just a little signage. It's basically a strip with an R, a Y, and a G, and the associated red, yellow, and green colors. And the nurse, based on the BROSET score, then flips it to the appropriate color code.
And we found this to be very effective and not onerous for the nurse. So we really want to kind of force function. If someone has to go look for a sign, you know, people get delayed and distracted and signs don't get posted. And we actually borrowed this from peers from Michigan Medicine. It worked well for them. And I have to say, it's such a simplistic sign, and you really don't have to have any patient information whatsoever on it. It's a color. And as long as you have a pretty robust education process, so everyone understands their responsibility, and that's how we taught it, is everyone in the organization has a responsibility for the signage. The nurse initiates it with the assessment, but everyone is responsible when they're entering a patient room to look at the color and respond accordingly. So if it's red, you should never be entering that room without other people with you. It's just to heighten your situational awareness on what you can do to help protect yourself and provide excellent patient care. So it's very respectful of the patient's confidentiality as well.
And another question in chat is kind of along those lines. How do you define workplace violence? For example, is there a difference between an intoxicated, belligerent patient who is hostile versus a patient with dementia who is scared and scratches a staff person? Is there a difference for the intent?
No, and we also consider verbal abuse as workplace violence. Whether that's from another staff member, a visitor, a patient, doesn't matter, it's all part of workplace violence.
And we do track that data based on if it's dementia, developmentally delayed, verbal, sexual. We track all of that, but regardless, it's all basically, it's still assault, it's workplace violence.
And if you research across that assessment, you'll find it's really a scoring based on behaviors that are being exhibited by the patient. So, confusion, agitation, some of those signs and symptoms that go along with dementia are in there. So it really doesn't matter if the person's intoxicated or if they have dementia. It's just scoring what are the behaviors so that you can take the appropriate actions to provide safe care for the patient and to keep our workforce safe as well.
And another question is about the flag in the EMR. That flag in the EMR communicates throughout the system. How does that happen exactly? Our compliance officer has not been very supportive of this due to concerns of inequity and profiling.
I'm trying to think of what it says.
It really in the EMR, I believe it just has the score. So the score of a green, less than 1, or a yellow,
1, 2.
yeah,
I know
or high risk.
when it goes to support staff, when like our transporters are going in there, they have, what are their little units called? They have units on their cards when they're gonna go do a transfer. And it doesn't give them the actual score, but it will just alert them that that patient has scored positive. So again, it's just giving situational awareness when they're walking into a room that they know that there is concerns with that patient that they need to follow up on before they go in there.
So it does come across through the EMR as positive. So it doesn't give a lot of information, but it is an alert that you take heightened precautions and really look at situational awareness.
Okay, if we could go into question number 3. This one we have Jeff Hawk, who is the Director of Public Safety and Police Authority for Memorial Healthcare. Jeff, who takes the lead on investigations or allegations, incidents of workplace violence at the facilities that you're responsible for?
Yeah, so for us at Memorial Healthcare, we're pretty lucky to have a licensed private police agency. So our internal public safety officers, police authority officers take the lead. Depending on the circumstances, they'll lead the effort and then they'll work with either internal or external partners. So if it's an employee versus an employee type of workplace violence, we would work hand in hand with our talent management human resources group. The area management of the areas of those employees, and then outside law enforcement if there's a criminal cause. Basically all other types, we're leading that effort and working hand in hand with our outside law enforcement agencies and then the county prosecutor on any criminal charges. We have had, we do from time to time trespass individuals. And so when we trespass an individual, that trespass is good for 12 months. We put them on what is called a banned patient list, and that is communicated throughout the organization. So most of those individuals are coming through our ER. We know them as they come through the ER, but we do involve all of those other areas of the organization. So in case they go to a doctor's appointment at a facility in a different county or so forth, that they would have that information. And a lot of times, as a pre-active or preventive, be involved to address those issues. Those recommendations for how we address the trespass after those 12. Then charges against that person, why the trespass was issued. We review any activity since that action, and then we make a recommendation to the executive team. Ultimately, the president of the organization determines what the final disposition of that will be, whether it's going to expire and they get a second chance, whether it's going to be extended for whatever an additional duration is recommended, or if they are going to be permanently banned from our organization. And then these items are reported through two different ways. So all of our incidents eventually make their way through our public safety report system in an officer incident report. We do have also a what's called safety net, and outside other areas and departments can report things through safety net. That goes through risk management or legal department. And potentially if it involves a patient or member of the general public, our patient advocate will also oversee those. And then we'll work together hand in hand on how to address those. And then kind of how we track our information as we move forward from those systems. We report those up. I report those through our environmental care committee as well as our workplace violence prevention committee. We maintain a public safety dashboard which tracks a number of different things, but including our workplace violence initiatives, our threat assessment tool tracking, and so forth. And then we also put together an annual report for public safety that goes to our executive team and our board of directors.
Our next question, if we could go to the next slide. For Sue, back with the Michigan group, what support and Sue, there's two Sues in the room. So this is Sue Logston, who's the Senior Workers Compensation Specialist for My Michigan Health. Sue, what kind of support do you guys have for your employees who experience any form of workplace violence?
Now, being in my role, I generally am the first
Sue, phone a little closer to you, please.
All right, is this better?
Thank you.
In my role, I'm generally one of the first front people that will speak to somebody that's been assaulted. And of course, the assaults can go from very minor to extremely horrific. My first goal with them is to make sure that that person is okay. Do they need any kind of medical attention? That is my first, where do I get to, where do I need to, if at all? If no medical is required, I do discuss our EAP, our Employee Assistance Program, with that individual. And that allows our employees 5 visits with a counselor that they can speak with. If they exhaust those 5 and still feel that they need counseling to work through that process, we will offer counseling through our workers' comp program for them. So we do offer outside counseling. We also, through our employee assistance program, it's called Aspire, we are in the process of setting up a workplace violence toolkit on our intranet. And it allows, we've kind of got documentation if we need crisis intervention brought in. This company will be there either through video or within hours. They can be on site to do crisis debriefing. So our EAP is pretty robust when it comes to that. They're have a lot of things that they offer. They bring counselors in that are specifically for the event that happened. If there was a death, if there was a rape, if there was, an extreme assault, they are available. They have specific counselors for whatever the situation is. When I'm talking to our employees, I also let them know that they have the right to file charges. During our assessment, we did find that people had no idea. They did not think that they could empower themselves to call the police and report that. So I always make sure that they're aware of that. That's their choice. It's between them and the prosecutor. I don't get involved in that, but I do let them know that they have the right to do that. I do follow up, whether there's medical, I always follow up, but even if they're just going through counseling, not that I'm being intrusive to ask what they're talking about. I just want to make sure that they know we care, that I'm following up. We want to make sure you're okay. Is there anything else we can do for you? So from my perspective, that's what I do offer our employees.
Share with everyone your title again.
My title is Senior Workers Comp Specialist. And I do feel, prior to, in regards to the question of the usage of our EAP, I do have quite a few people that use that. We have not fortunately had to call in for debriefing or crisis, anything like that. But I have had quite a few of our employees that have been assaulted utilize our EAP. Is it underused? I would say it probably was, but we are, through our toolkit, through our education and our communication of what we're doing, we are really bringing this forward to our employees that this is available for them, specifically for when they've been assaulted.
Going to our next slide then. This is the last of the planned questions, and then we're going to get to the chat. And this last question is for Sue Lennon, who is the Director of Employee Health and Wellness for My Michigan Health. And Sue, how are workplace violence policies and procedures communicated? Not just to your staff, but to maybe the patients and the visitors that come to your facilities too.
Okay, can you hear me okay? Or do I need to move closer?
No, you're good. Thank you.
Okay, we kind of covered some of this with previous questions, but we communicate in a lot of different ways. So internally, we communicate our policies. Obviously, it's kind of a top-down approach. So the executive team and leadership approves our policies. Our CEO communicates much of what we're doing with our task force and her video updates, which are monthly and quarterly. We report up to the board every quarter our statistics and any new initiative we may be working on. We communicate, as Sherry said, through the newsletter every week, on our internet homepage. When we're doing new initiatives like the Brosset scale, we took a grassroots approach, and we're a hospital system. And so geographically, we have quite a span here in Michigan. And with Brosset, because we really wanted it communicated well, we used all of our normal communication tools, but we actually went to departments and got on their meetings and on their agendas, and we met in person. And that was very empowering because we could explain what we were doing, but then we could hear from frontline staff additional concerns they might have, and they felt very well supported. And we can't do that with every initiative because it was really laborious to do, but it was a very effective way to communicate a new initiative that was so important. We also do daily safety briefings at every one of our facilities at 9:30. And every department reports whether they're safe or if they have something going on. So a lot of our communication will be done at daily safety briefings. And that's been a really good tool because then you can have huddles afterwards and discuss what's going on. And really with the Brosset scores being so new with the signage, our push is for that to be communicated on the unit and their shift change huddles. We would like to see that brought forward to the daily safety briefings, at least how many breads do we have on a certain unit, because security's there as well. So it's just a way to communicate level of risk in different locations. Trying to think if there's any other thing. And for patients, our signage that we posted, no weapons allowed, and our signage regarding behavior expectations, that really is for visitors. Patients they get a admission packet that talks about, expected behaviors, and so we communicate that way. But the signage was also to help communicate with visitors coming in what our expectations are. So I think that is pretty much how we communicate our policies and procedures. We have a whole online education program. So when we developed our workplace violence policy and procedure, it was assigned to everyone through that system. So everyone had to read it and acknowledge that they read it.
Okay, that's the last of our pre-scripted questions. Katie and Rebecca, Becky, is there anything? I know there's a lot of questions in here. Anything you need to address?
One of the questions is, do you have data on the usage of your EAP? Nationally, it is underutilized if the victims have to help seek themselves.
Just speaking from my Michigan health, we do unfortunately have the data in front of me, but our comp and benefits team does have the data on utilization rates. And I do know that since we now have implemented with Sue's investigation, that we make sure and we offer that to anyone who's reported an incident, that the numbers have increased somewhat. But unfortunately, I don't have the data in front of me that says what our utilization rate is. I do agree with the person who put it in the chat that, historically, it's underutilized, and why is it underutilized? I think it always falls back to communication, people not realizing, oh, EAP does have counseling, so I think it just comes back to communication. We have been putting it in our newsletter so people, see that, and when we do our open enrollment, this time of year, we're also letting people know about EAP as well.
Jeff or JP, do you have any insights that you could share about your employee assistance program usage in your facilities?
I know for us here at Memorial, we experience, I think, pretty much the same thing that we're talking about today is it's there. We communicate that it's there. We want people to take advantage of it, but for whatever reason, it's probably an underutilized resource.
One of our hospitals, which I find very interesting, is they have a full-time social worker who goes in to triage any situation that occurs. But then they offer multiple resources beyond EAP. She also can refer them to other people within the hospital that are social workers or behavioral health specialists, and they also provide other type of therapy beyond EAP, all of which is free or covered by insurance, because that's so I really like that idea, because some of the things I've been hearing about EAP from other hospitals is that sometimes the wait time is extremely long to get a hold of people because they're understaffed as well. So I think this hospital approach, instead of just giving an EAP number, is highly effective.
Can I just speak to the EAP as far as our perspective? What we did when we started this, we actually met with EAP. We sat down. What exactly do you have to offer? These are our situations. What can you do for us? Because if you're just calling them and saying, just say I needed something and I call, it does take them some time to get back with you for counseling. And when we said, look, we've got somebody that has just been assaulted, they're a wreck right now, what can you do? And come to find out, they will, whatever time of day or night it is, if we meet them, they will get on a website, they will, whether it's Teams or whatever method it is, they will get right on. So it might be worth sitting down and speaking with the EAP, because our EAP will be there in a moment's notice. And if we need them on site, they said they would be there within hours. So it was a real big value to us to really sit down and speak to them to find out what they could offer. And we chose to go outside of our system to do all that. We did have a handful of people here that were trained to do debriefing, but we found that employees have difficulty speaking with their own employees, that it was easier to speak with somebody outside the company. So it discontinued using our internal people to do that, and it's stuck with EAP. And so far it has worked really well for us in that way.
And I know you kind of answered this question in chat, but somebody asked, could you share your signage? Is it public currently that people can take a look, or will you just share it after?
And we're happy to share a picture of our signage. We can just send that to you, Tracy, and then you can send it out with the video.
And our signage are our real violence, and that our signage was really modeled after the Michigan Hospital Association poster.
I guess that's a good question. Are you asking about the signage for the Brosette school, or are you asking about our kind of "we don't tolerate violence" signage? We'll send pictures of both.
And kind of along those same lines, we've gotten some requests for, is anyone willing to share their plan? So think we might have to, I'm sure you guys would have to check to see if you could actually share your plans. But if we are able to do that, I'm happy to distribute whatever information you guys are willing to share. Or maybe I put up these contacts. If there's somebody you're interested in reaching out to directly about their plan, all the contact information is here. And of course, these slides will be shared so that you have this these subject matter experts' contact information moving forward too. Any other questions, Katie, that you've?
Yes, there's another one. How are you aligning vendors and ensuring workplace violence is addressed in relation to the vendors?
No takers. Jeff, do you deal with the vendors that come into your facilities as the public safety lead?
Yeah, so anybody coming into our facility is treated and the expectations are the same for anybody, whether it's vendors, contractors, or the general public.
We have, again, my mission is called vendor mate, and then there's a bunch of stuff that's in there, and we share the kind of same thing, the policies, procedures that are pertinent to the vendors, and make sure that they have a code of conduct and they understand our policies and procedures. That's how we do that in my mission.
Katie.
So someone put in the chat some of the resources of the posters, workplace safety posters. But that looks like most of the questions. People have said this is very helpful, so thank you for all the information.
We do have a workplace violence compendium, a resource compendium that we've put together that is, I believe, done with communications. I think it needs one more person to bless it before we can share that and put it in the resource library. We also I can share that Brosette assessment, but if you can't, you're anxious to get a look at that, you certainly can Google that. Brosette is spelled BROSET. Here again, all the information for our subject matter experts that we have with us today. And I thank you all for joining us. JP, from a legal perspective, do you have any closing thoughts on this topic? Because I know the lawyer in you has been taking notes. I've seen you writing.
Yeah, I've got some good ideas here. I think it was a good.
Can you come a little closer to?
Yeah, I'm sorry.
That's okay.
It was a good question earlier about how you report differences between people that come in intoxicated or just angry versus some form of dementia. My mom, towards the end of her life, I had to go into the hospital to help deal with that, deal with her when she was lashing out. And they were surprised I showed up. That was before I took this job and really understood what the issues were. But where it's really coming up are the criminal statutes. Missouri has I think has good language in there that makes exceptions for people with mental health issues. But I think that's the part I'm really grappling with right now when there are more criminal statutes like Kentucky. We helped enact the Kentucky one is when is it intentional versus someone with dementia. So I think that's the issue. The criminal statutes are not a panacea to resolving this issue whatsoever. But I really like the answer that I think it was Michigan that gave of how they still report everything and just seeing it as an incident. So I thought that was really good, just what the next step is for when the police get involved. Because the other part is the nurses and other staff don't necessarily want to be a witness. They're scared of the folks and they don't necessarily want to put themselves forward there. But if criminal charges are brought, they have to be a witness. So those are those are issues to think through when charges are brought.
Travis has brought to our attention not to overlook the resource of your chaplains in your facilities. I think that's a great point to bring forward, kind of as a force multiplier for your EAP resources. Any other questions before we bring today's session to a close? All right. Again, I thank you all for joining today, and I thank all of our panelists for the planning that went into this and to setting aside time to talk with us today on this really important subject. I think it's something that everyone is having to deal with, and the more we talk about it, the more prepared we'll be to address these issues. I'd like to thank Katie and Becky and Lynn for helping run today's events. I am someone, oh, here's one more question. Does someone have a data collection form which spells out types of workplace violence? We do, that is included in the workplace violence compendium that iPro has put together. We are going to share that with you, but that definition can be found on the OSHA website as well as the Joint Commission website, and they're very specific, very long, specific definitions. So again, we're going to share the slides, we're going to share the resources that we talked about, and you have all the contact information if you have any follow-up questions or clarifying questions for our subject matter experts that were with us today. And with that, I think we're going to bring everything to a close. And thank everyone for joining us. I wish everyone a happy Thanksgiving. It's just coming up around the corner next week. And look forward to receiving these resources in your inboxes. Thanks, everyone.